Hi, I'm Atulya Kharbanda, Priority Global Health Extern at Rochester Institute of Technology, and I'm here to present our research on cognitive behavior therapy for the homeless in India, adaptation and digitalization. For a quick overview of psychosis, psychosis is commonly understood as a condition that causes one to lose touch with reality. For a more comprehensive understanding, ICD defines it as the presence of hallucinations, delusions, or a limited number of severe abnormalities of behavior. This condition may be triggered by a mental illness, a physical injury, a physical illness, substance abuse, or extreme stress or trauma. It's quite a prevalent condition in India, and the statistics somewhat look like 1.41% across a lifetime and 0.42% in terms of the active number of cases. And these statistics are in alignment with the findings of NIMHANS in 2016. As a part of this global externship that we're doing, we provide psychotherapy at a homeless shelter wherein almost 25% of the population has reported to be experiencing either hallucinations or delusions, and almost 20% of them have been formally diagnosed with schizophrenia. To understand the cultural context of psychosis in India, it's important to note that India attaches a lot of non-medical causes when it comes to psychosis. Some of these include karmic deeds, magical or religious influences, family problems, and hence even the treatment options that they prefer are somewhat non-medical, like religious or temple healing practices, prayers, traditional healers, shamans, and things on those lines. Hence, what we're trying to do here is to adapt cognitive behavior therapy for psychosis for the homeless in India. There's a huge gap in that domain which needs to be filled because there is lack of awareness, there is lack of accessibility, and to fulfill those aspects is what we're doing through the work that we're doing in this study. How we plan to go about this is by recruiting approximately 100 subjects who will participate in this project, and participation will be in the form of 8 to 12 weeks of 45 minutes to 1 hour long weekly sessions. These participants will be recruited from a homeless shelter where we're currently providing these therapy services. And as a part of this study, they will complete a psychosis digital screener. They will be engaged in the culturally adapted version of CBT that we are developing. And additionally, they will also be engaged in the digital exercises for out of session practices. The aim of this manual that we are developing is not just illness management, but an overall well-being perspective. And therefore, some of the other tools keeping that perspective in mind that we would be using would include PHQ-9, GAD-7, DSM cross-cutting, intake forms assessing pre and post distress levels, and progress notes. So there are two parts to the work that we're doing. One is the adaptation part and the other is the digitalization part. The reason we took up the digitalization part is because of some imperative needs that we identified working with this population. Firstly, there is an overall paucity of practitioners in India at the moment. Secondly, with the pandemic hitting, the accessibility, the physical accessibility to these practitioners even reduced. And generally, the amount of ignorance at a social level for the needs of this marginalized community is high. So keeping all of these logistical problems in mind, it was understood that going partly digital with our approach to CBT for psychosis will help us cater to a larger population. As popularly known, digital platforms are scalable, they are cost effective, and have shown to increase engagement in out of session exercises along with the therapy practices as well. What you can see on the screen is our developed Rich CBT, which is an interactive and self-guided platform. It was previously built on proven CBT methodologies to address substance abuse and aggressive behaviors. It is now being trained to be used for psychosis, and its language has been changed from English to Hindi, given that um, most people in India speak Hindi. What some of the other things that we're working with this avatar or are the age, the complexion, generally the background, to make it more accessible, more relatable to the people of India, particularly the homeless population that we're trying to deal with here. So that was the digitalization part. The other part of this project is the adaptation part. So we chose CBT for this particular adaptation, specifically because CBT has been found to be highly efficacious for psychosis. Research backs that. Additionally, research also backs that when CBT interventions are provided at an early stage, when symptoms have just started to develop, the dysfunctionality that has been noticed through the course of psychosis has been found to reduced. So that was another reason. The third would be that CBT for psychosis was noted to particularly be effective for positive symptoms like hallucinations and delusions more than the negative symptoms, which are more salient and have been reported to cause more distress than the negative symptoms among the patients, as shown in research literature. However, there's a lot of data available that CBT for psychosis is quite efficient and efficacious. Unfortunately, most of this data comes from the Western world, and their parallel testings have not been done in the non-Western parts of the world, and hence this study, this adaptation covers that. What we're doing here is we're adapting Smith et al.'s CBT module for psychosis. We specifically chose this particular module by Smith et al. Was because of its close alignment with Indian values. For instance, it focuses on the experience of symptoms rather than just the diagnosis. Secondly, it pays equal attention to symptoms as well as the distress that these symptoms are causing. So given these alignments, as well as the well-being perspective that the manual takes, it seemed like a right fit with the Indian values. This manual aims to increase insight, improve coping, reduce distress and preoccupation with symptoms, and prevent relapse ahead. This current research, what we're basically trying to do is we're adding a cultural lens to how we see psychosis. From symptoms to intervention, to role of therapist, to homework, to meaning of illness, to meaning of well-being, every single aspect that is important for understanding psychosis, we're adding a cultural lens to that. It has been shown in research that culturally relevant approaches achieve more commitment in therapy from patients. This study that we're doing, it is expected to make cognitive behavior therapy more relevant to the Indian population, and particularly to the homeless population within India, and hence it is anticipated to increase accessibility and fidelity to treatment. Thank you so much. If there are any questions, comments, feedback, please feel free to reach out, and there's my email ID on the screen as well. Thank you.